standardize it. And that continues into the 20th century.
Over the course of time, it became very clear that psychiatric diagnosis was very unreliable. The two different people looking at the same patient, two clinicians looking at the very same patient would come up with a different diagnosis, and that meant you had no reliability in terms of what the right treatment was. DSM-3 in 1980 introduced the innovation of providing criteria for each diagnosis, so that clinicians working all over the world would be working off the same page. And it did at the time greatly increase the reliability, the agreement amongst different people looking at patients.
The foreword to the manual says it's used by psychiatrists, clinicians and researchers to define and classify mental disorders, which can improve diagnosis, treatment and research. The DSM is followed in America, Canada and Australia. Other countries use a mixture of the DSM and ICD, the World Health Organization's categorization level, but they're very similar, and it's the DSM which often takes the lead.
Basically, DSM could be viewed as one of the two major descriptive schemes of mental disorder.
Dr. Heidi Low is a psychiatrist based in Hong Kong.
So in my day-to-day clinical practice, I would say DSM is my reference tool because it offers detailed framework which help me identify the specific symptom clusters associated with each disorder. We use it for medical student education, teaching, and psychiatry trainee training. Both DSM and ICD-10 are used by Hong Kong clinicians and psychiatrists, and it differs a bit, but after all, we still apply our clinical judgment beyond the guidelines in our practice.
Dr. Jared Ng is a psychiatrist who, until recently, headed the Emergency and Crisis Centre at the Institute of Mental Health in Singapore.
We do use the DSM, even though it is a product of the American Psychiatric Association. All the psychiatrists are expected to know the diagnostic criteria for DSM. I think all of us would use the DSM when it comes to classifying a person with a mental health condition. We use it to guide us in coming up with a diagnosis. But having said that, I must say that we also use the ICD in Singapore. The DSM is more clinical. The ICD covers many other conditions. Sometimes we still do refer to the ICD for certain conditions may not be so adequately covered in DSM, especially the latest version. For example, autism spectrum disorder is all combined into one single diagnosis in DSM-5, whereas ICD still maintain a very nuanced approach. It's still divided into different types of conditions like autism, Asperger's, pervasive developmental disorder. And sometimes we find that this is a little bit easier for us to explain to parents.
Dr. Sabrina Anjara is a psychologist from Indonesia. She says learning the DSM was an essential part of her training.
Interestingly, all medical students in Indonesia learn about mental health disorders using the ICD-10, but psychology students, clinical psychology students, learn using the DSM. Now, in the public healthcare system, Indonesia came up with a hybrid of the two. They locally adapted the ICD-10 and DSM-4-TR for use in the diagnostic of psychiatric disorders.
But Sabrina says it wasn't until the mid-early 2000s when most Indonesians began looking for help from medical doctors.
It is still, till very recently, a very conservative society where magic and demon possessions are considered to be the main reasons for alterations of a person's character or behavior. And so the go-to person for any symptoms of mental health disorders would be shamans and religious leaders. It is only recently, and I would say after the Boxing Day tsunami in 2004, that Indonesians started going to primary care centers for help with any mental health symptom. In the early noughties, we only had around 700 to 800 psychiatrists in a country of over 200 million people. And right now we have 270 million people, and that number hasn't increased much. But the number of psychologists have increased quite significantly. We now have around 2,000 psychologists, and there's also an increase in prevalence of diagnosis. For many individuals who were labeled with being demon possessed, or perhaps not religious enough to the point of having delusions and hallucinations, they're actually finding a diagnostic label to be validation of their experience, and perhaps to a certain extent, if it gives them hope that they too can recover like other people with physical health problems. Having a diagnosis can also mean that there will be a treatment plan in a health facility, and that's a far more appealing option to many Indonesians to being shackled in a forest or chained in a windowless room.
DSM is reviewed and updated every decade or so. It began with DSM-1 in the 50s. DSM-2, DSM-3 and DSM-4 followed, and now it's in its fifth volume, DSM-5, which came out in 2013. But there have been some revisions since then to keep it up to date. So, how does the American Psychiatric Association come up with the disorders it lists in the DSM, and where's the science underpinning it? Vesper Moore is a mental health activist based in the States.
Basically, it's a theory or like a proposal of a condition that is brought to a committee when they revise the manual every few years. But when they revise the manual, generally it is a group of psychiatrists who are a selected few on this committee who decide which diagnoses are categorized.
The evidence is reviewed, they bring experts in.
Former DSM-5 Working Party contributor Michael Sharp.
The experts read the evidence, they argue, they communicate, they put their proposals forward to central committees who maybe push it back again and say, no, that will... Opinion based on evidence.
So I would say it's a process that relies heavily on scientific data.
Chair of the current DSM Steering Committee, Paul Applebaum.
But scientific data don't assemble themselves into proposals. And there are inevitably matters of judgment that have to be reached. So, for example, how much data supporting the validity of a proposal constitutes enough data to warrant its adoption? Where should cutoffs be set? Data can certainly help in setting cutoffs. Sometimes they can be something close to definitive, but the application of human judgment is inevitable in addressing many of the questions related to the formulation of diagnostic categories.
There are advantages, of course, because it puts some sort of order into a previously quite chaotic state of affairs, where everyone has